Thank you very much, Ajahn Prapan, and it's truly an honor to be invited back to the Bangkok Symposium and to be here with all of you. I'd like to spend the next 20 minutes to share with you some information about acute HIV infection and its treatment and its relevant to HIV cure in children and in adults. And I'd like to start off with talking about why acute HIV infection is important, sharing with you some of our own data from Thailand on viral load kinetics, how to diagnose acute infection, the impact of early treatment on the reservoir and serology for HIV, and then finally, we have also data from Thai infants on what happens to their reservoir while they're on ARV prophylaxis and also on treatment. So I do hope that this will be useful information for you in your work, and I look forward to your questions and comments at the end. So why is acute HIV important? And here when we talk about acute HIV infection, we generally mean about the first 4 weeks of infection. And you can see here, this graph shows the days following transmission on the x-axis. And this period is when viral load rises very rapidly. And it's when we start seeing more and more cells become infected. There's CD4 depletion. CD4s are killed from the gut. The tissues are infected. The immune system is trying so hard to control the virus, and it's getting exhausted, and then the ability to control virus later on is less. And as you know, HIV mutates every single day, and so the number of days that pass that we're not treating our patients, then it evades the immunity. And perhaps very important for the public health field is that this is a period that HIV is very efficient in transmitting from one person to another. And in our own study, the acute study here, the SEARCH 10 cohort, mathematical modeling data have shown that if we don't diagnose people with acute infection, don't treat them, one person has a chance to transmit to 25 people during this acute period. But if we treat them, diagnose them, their viral load suppressed, this risk goes down to 1 to 2 people. So that, I think, is really important. So another thing that is so important is that treating early may help people get to HIV remission. And here HIV remission means that if someone is HIV positive on ART, they're able to come off treatment and still have undetectable viral load and be healthy. This is a goal that is the near-term goal for the field, and there's another goal that we aspire to, which is HIV eradication, and that means getting rid of every cells that are capable of making HIV. So here is a slide that shows the viral load graph, and the x-axis is time off of treatment or duration of remission. And you can see in the typical patient, the blue line, if someone stops ART, viral load will come back in less than 2 months. We have seen that in some cases that have had bone marrow transplantation for their cancer, in the case of the Berlin patient, Timothy Brown, who had HIV-resistant cells, he's been in durable remission for a decade now, and perhaps he might be our first case of eradication. The Boston patients have been in transient remission for a few months, but this is not a treatment we would try for anyone who does not already need transplantation. So another way may be to try to treat very early, and we have seen the Mississippi child who was treated in the first 2 days of life and was in remission for 28 months, and then adults in the Spartek, Visconti, and other cohorts that have been in remission for several years. So you might say, well, the treatment guidelines now say everyone who's diagnosed should be treated anyway, so why is it important to know if someone is in acute infection? I would say it's very important because the urgency of starting treatment is there. If you have an acutely infected person in front of you, you want to start treatment that day or maybe the next day. You don't want them to go back home and come back several weeks later. You now have lost the opportunity to reduce the HIV reservoir significantly, preserve immunity, and prevent transmission. So I'd like to share with you some data of 2 cohorts that are being done here in Thailand by the U.S. Military HIV Research Program and the Thai Red Cross. The left one, RV217, is led by Dr. Merlin Robb, and this is a study in East Africa and Thailand where people who are not yet infected but are at high risk of HIV infection, they come in and get finger stick twice weekly for nucleic acid testing. On the right is the search cohort that we do at the Thai Red Cross. We routinely screen samples from clients who walk in to the clinic for acute HIV infection, and you've seen here that we have screened over 200,000 samples so far, and we have over 400 people in the study. So in the RV217 study, this is for the first time we're able to see what the viral load kinetics in acute HIV infection is. So the x-axis here is days from the first viral load that is positive, and the y-axis is the viral load, and each line represents a patient. You can see that as soon as viral load becomes detectable in the blood, the viral load rises very fast. Within 13 days, it hits its peak, which is in the millions copies per mil, and then just 2 days after the peak, the HIV antibody becomes positive. And then the viral load set point happens very early too. By a month or 40 days, people come down to set point, and where the set point is has been shown in previous studies that determines disease progression. So immediately this shows us how dynamic this period is. So how about symptoms during acute infection? And when the viral load is rising very fast, hitting its peak, that's when we generally see people with symptoms. And so I'd like to share with you some data from Thai people who we have enrolled in our study. These are about 400 people who have acute infection, and almost 80% display some symptoms of acute retroviral syndrome. And the most common symptoms are the systemic symptoms of fever, myalgia, headache. We see quite a bit of sore throat. 2/3 of the people had sore throat, some have oral ulcer. You can see GI symptoms are also quite common. What was not so common was adenopathy, and I used to learn that this was the hallmark of acute retroviral syndrome, and this may be something that is different in Thai people. I see many of you taking pictures. I'm giving all the slides to be put on the website, so don't worry, okay? And you can also email me, I'll send them to you too. So how do we diagnose acute infection in the SEARCH-10 study? And so when people walk into the Thai Red Cross Anonymous Clinic, what they get is the 4th generation antigen-antibody combo immunoassay, which is, many of your hospitals also use that. So for the research study, we do additional testing. So out of the 200,000 samples in the Anonymous Clinic, this is from April 2009, about 14,000 were positive. So normally in a clinic, they would be told they're positive, and that would be it. And the majority were non-reactive. And so in our research study, we do a less sensitive immunoassay on the reactive samples, and we do pooled nucleic acid testing to test for the virus in the negative samples. So in the reactive 4th generation, we found that the majority were reactive with the less sensitive methods too, which is not surprising. Most people who test positive are in chronic infection. But we did find about 400 people who were still non-reactive with the less sensitive test, meaning they have antigen, they have HIV IgM, they don't yet have HIV IgG, so they're still in acute infection. Now, in the arm that were non-reactive, the majority of people are uninfected, and that's not surprising. But we did find 100 or so people who had nucleic acid positive, so they are in the very, very early stages of acute infection. They have not yet developed HIV antibody. So what if you were in a setting where you don't have nucleic acid testing, which is most settings? How can you identify acute infection? I would say very important to have high suspicion for infection. With people with febrile illness, often the history of exposure to HIV is not asked, and if there's high suspicion, then they should come back in 1 week and maybe at most 2 weeks for repeat testing. There are new diagnostics, and this Bio-Rad Genius assay is now approved in the US and is replacing Western blot. So if you have someone who's 4th generation positive and they're indeterminate or negative by Genius, that suggests that they're in acute infection. So this is a very, I think, good test because it's automated, it takes 30 minutes, and you can see the different bands for HIV-1, HIV-2, and immediately you can say, if people are positive, if they're not yet positive by Genius, then they're in acute infection. And another way is to use information already available in the system. So if you see someone with discrepancy between results of the sensitive and the less sensitive test, that suggests acute infection. Also, the fourth generation immunoassay that we all do, the lab has values that normally they don't report, but we can ask for, which is signal to cutoff ratio. And so here are data that have been published showing that using the Architect fourth generation immunoassay and looking at the signal cutoff ratio in people who are negative, people in acute infection, and people in chronic infection, there's quite a difference. So if you have someone who is non-reactive by the HIV rapid test, so that's a less sensitive test, plus having a signal to cutoff ratio that is very high, that suggests that they may be in acute infection, and you would need to confirm with a viral load or other testing. And if they have an SEO that is positive but a previous test that is negative, that also suggests that they might be an acute infection. So I think that the field now is pushing towards, if there's any inkling at all that someone might have acute infection, you start treatment that day and then do viral load and wait for the results. And if someone is truly in acute infection, they have received early treatment. If they don't have HIV infection, they come off ART. And ART is being used in PrEP and PEP, and I think it has shown quite good safety profile. So that's another approach that might be taken, I think, in the future. So what is the impact of early treatment? I'd like to show you some data from our search cohort. So we use, generally the regimen that we use is tenofovir, FTC, 3TC, and efavirenz, and for a period of time we were also randomizing people to adding raltegravir, which is an integrase inhibitor, and maraviroc, which is an entry inhibitor for the first 24 weeks. So here is the viral load on the y-axis, the x-axis showing from screening to 3 years. You can see that the viral suppression in our cohort is very good. The difference between two regimens is not so much in the long run, but in the initial period, people who got raltegravir had a much faster decline in the viral load. It took 55 days to get to viral load undetectability with raltegravir, and it took double that if we did not have raltegravir. Now, we don't know yet if this is really going to have significant benefit in terms of prevention and treatment, but it may, because having viral load decline so fast early on may help with prevention and may help with treatment as well, but that's something we have to study more. Now, we have also looked at the reservoir size, so basically how many infected cells in the body by looking at total HIV DNA in the peripheral blood mononuclear cells. And here we compare data from the RV217 Thai people who did not at that time receive treatment in the blue line, and the red line are the Thais who got treatment as part of Search 10. So you can see when they enroll about 2 to 4 weeks following onset of infection, and the arm that didn't get treated, the reservoir size, the infected cell number, increased significantly, very rapidly, and doesn't come down that much, and sets the stage for the amount of cells infected in chronic infection. In fact, the difference is very apparent very early, 20-fold difference in the total HIV DNA, and 300-fold difference by 3 years. So I think it's so important that if we have the opportunity to diagnose someone with acute infection, we should try our best to start treatment as soon as possible. So another thing that I think is a true benefit for people, especially in Thailand, where stigma of being HIV positive is quite significant, in that people who get treatment very, very early, within the first 2 weeks before they even seroconvert, they remain seronegative for a very long time. And here is the percent non-reactivity by the most sensitive test that we can do in people who started treatment from within 2 weeks of onset of infection in red, and people who start treatment later but still in acute infection. You can see that 6 months after ART, so meaning that they've had HIV for more than 6 months, 60% are non-reactive. So, you know, and this continues even afterwards, after they've been on ART for a long time. And I think this is quite a social benefit of early treatment. So how about infants? I think infants are so unique because we know the timing of HIV infection in most infants. It's at time of delivery. And the immediate diagnosis is standard of care. The immediate treatment is standard of care. And so we have a real good opportunity to try to make a difference in this group of children. So the immune system in infants are also unique, that it might benefit in terms of the chance for HIV remission. Infants have higher naive CD4 T cells that are more resistant to HIV. They have very good thymic output. They have better immune recovery than adults, and they respond better to almost every vaccine out there. And we could believe that they would respond better to HIV vaccine, therapeutic vaccine as well. They have less immune activation, which is beneficial, because they also have, in terms of B cell and the typical CD8 T cells that are still in development, that might put less pressure on the immune system, and they might have less immune escape. Their cells are less able to respond to new antigens. So these are data comparing our Thai early treated infants and the Thai early treated adults. And you can see here, this is the percentage of CD4 T cells, comparing naive CD4 T cells that are more resistant to HIV. The infants have much, much higher naive CD4 T cells, and they have lower central memory CD4 T cells that are target for HIV. So this may be a very favorable profile for infants compared to early treated adults. Now, we also looked at reservoir size in these infants, and here are infants who are still receiving ARV prophylaxis. So they have not switched yet to treatment. And you can see this is the reservoir size on the y-axis, the integrated DNA in peripheral blood cells, and the y-axis and the x-axis is the viral load. And here there are two groups of children, the children who got AZT only for prophylaxis, and those who got the triple drug, and the nevirapine here is a prophylactic dose. So you can see that if the viral load is high during the period that infants are on prophylaxis, they actually have higher reservoir size. And so this brings us to the question and to our ability to try very hard to diagnose children early and switch them from the prophylaxis to treatment as soon as possible in order to try to lower the viral load as fast as we can and then lower the reservoir size as well. So we also looked at the reservoir size by time when children started treatment. So here we show the reservoir in the y-axis, and the x-axis showing children who started treatment before 8 weeks of age versus after 8 weeks of age. And if they start treatment sooner, they have lower reservoir size. And so this goes to, we don't want even a day or a week to pass when we know an infant is infected, we switch to treatment immediately. So, however, it takes such effort to track and to diagnose one child, bring them into care. And unfortunately, the viral suppression rate is quite low. And this is not just Thailand, it's every cohort in the world. It's very hard to suppress viremia in children. And here, this is data from August 2014 to December of last year, 168 infants diagnosed with HIV in Thailand. The median viral load of about 100,000. 6 months and 12 months after ART, you can see a year after ART, only half of viral load suppressed. This is much, much worse than the adults that we treat. And this is because, ART is not very good. I mean, they have to take lopinavir liquid, which is very hard to take. And I think that we do need better ART for these children. We don't have a lot. It's manageable, and I think we have to think about getting raltegravir for these infants and to help them get through this first year, 2 years of life when they can take other regimens easier. And I think frequent viral load monitoring is also important. This is not a lot of investment for just 100 or so children. We can't do viral load once a year in these infants. It's just too late. And then psychosocial adherence support is so important. I mean, these children are born to teenage mothers in social situations that are not ideal. And I think that we have the opportunity to really impact their lives, that we can help them a little bit more. So I'd like to conclude that acute HIV infection treatment, the earlier the better. We see reduced reservoir, preserved immunity. We can prevent onward transmission. And this morning you'll hear talks that are very, very relevant to HIV remission and cure. You'll hear talks about strategies towards cure, tissue reservoir, opportunistic infection, immunity. What do we do if people start treatment late? And why do people join and not join cure trials? And so I do hope that you stay for the whole morning and hear all these talks. And so I'd like to end with acknowledging our study participants, both the adults and children, their families. They give so much in the name of science. Our study team and sponsors and all the people here who provided information, data, and input. Thank you so much.
Thank you very much, Dr. Jintanat. This is the first time for the whole meeting here that we can finish on time, and we have some 10 minutes or so for questions and answers. Before anyone come up to ask any questions, I forgot to mention that next month Dr. Jintanat will be the plenary speaker at CROI, which is the highest achievement for any scientist to speak in the plenary in CROI, because Jintanat has been speaking in several meetings organized by IAS, World AIDS Conference, IAS Pathogenesis, and then now move up to the CROI level. So it's our great achievement for Thailand as a whole.
And then, thank you.
Okay, so please entertain some questions from the floor. No one will ask anything because they would probably, some of them will just follow Jintanat's talk and CROI next month in Seattle. Okay. Professor Kiet, please. No, you just have a microphone there. But it's very nice. For those of us who come from developing countries, Jintanat told us how we can diagnose acute HIV in our resource limited settings. It's a very important lesson. Kiet.
Hi, Jintanat, always a very good talk. The question is in the kid that, in the patient that had been treated very early and didn't show seroconversion, and you said that even after 6 months. So how long you have been, seeing that they remain seronegative? More than years or even?
Years, yes. And we haven't done serology for the whole cohort for that long, but we have done in a number of people, and even 2 to 5 years after, they're still seronegative. Yeah.
So the potential for cure and potential for seroconversion is something that we will tell our people in our country that this is probably the reason that you should come for early HIV diagnosis and treat it.
I wouldn't say for cure because we're very far off.
Okay, so if there's no more questions, please go ahead.
Thank you, Ajahn Jintanat, Thananda from CDC Thailand. Your talk always very impressive. I'd like to ask in terms of public health program, do you anticipate that would the acute HIV infection treatment will be part of the WHO recommendation in the near future or sometime?
Yeah, I mean, I know the WHO has had now several meetings, think tanks, to try to think about that. And so I think definitely they have intention to look into how to incorporate this into the guidelines, but whether it gets in or how it's done, I think we have to wait.
Okay, Professor Kun Kanya.
Hello, Jean. Excellent talk.
This is your gift. I wear it everywhere.
That's beautiful and shining on you. So thank you for an excellent talk always. My question is regarding the reservoir in the newborn babies. People try to use more drugs, more than lopinavir. You see, the problems not just that we cannot initiate treatment as early as we want by several reasons, but also would that be something that you would anticipate to be maybe starting in babies first, maybe for drugs, initially, as we know that there might be some NNRTI resistance in the mothers. Recently, as we treat for all, mothers are likely, to have higher rate of primary drug resistance. Infected newborn babies who are receiving NNRTI prophylaxis regimen during pregnancy and become infected, breakthrough infected, then probably NNRTI resistant somehow, and nevirapine wouldn't be a good choice. Right. And is there anything that you think maybe would relevant? But again, they might have got wild type virus anyway. Yeah. So, in some of the protocols, they suggest ACT, 3TC, nevirapine, and lopinavir, 4 drugs altogether. How do you think, as the initial regimen for babies, or even raltegravir in the future, which I think it's going to be a long time, but maybe they'll take away first or something like that. Do you think bigger or more drugs to put into the routine regimen would be better?
Yeah, I don't know. I mean, I know the Europeans are, they normally start 4 drugs in babies. I think better drugs would be better than more drugs, and I think that lopinavir is a problem in this age group, and I think that if we can use raltegravir up front, and it's approved down to a very young age now, and I think Tanyawi is trying to work with the company. So as a group, maybe we have more power and more, to try to go with the company. At least for Thailand, we're not talking about a lot of children. And I think that if we can start raltegravir earlier, that would be better. And the other thing is the impact P1115, the ARV prophylaxis, the nevirapine dose is a treatment dose. Exactly. And we use nevirapine prophylaxis dose. Now, we discussed this, and it is a problem with diagnosis. If we use treatment dose, some of the diagnostics that we're using now in Thailand may not pick up the infection till a little bit later, but that's also something we have to weigh in.
Well, thank you.
Okay, I hope you agree with me that whoever faces shown on the screen are much prettier than the real face. So please sit behind the microphone, whatever, and then you will be shown up there.
It's terrible. Nice. This is one change I don't like about the Bangkok Symposium.
So I have finished. The last question, and then we can have to go.
Thank you, Dick from Vietnam. Thank you for the presentation. That I just noticed in the presentation that only 50% of the child got viral loss of breath after 1 year of AIV, and even though that's children using lopinavir, ritonavir, and WHO guidelines still recommend to continue that failing regimen after 1 year if the children is using lopinavir, ritonavir regimen. Yeah. So what do you think in terms of making the viral load spread for those children? After 1 year, you test it and you see that viral load is not spread. So what is your suggestion for changing regimen apart from the WHO guidelines? Thank you.
It's a very hard question because, we're limited to what we have. So I think from the WHO point of view, I mean, even when you're failing on a PI regimens, mutations don't, occur very much, and most of the time kids are failing because they're not being given the drugs. So, if I don't know what else you have in your country, but if you are able to test for resistance at the initial outset, or there's samples stored, and you determine that the child doesn't have NNRTI resistance, then if they're not taking lopinavir at all, then that might be an option. But that's also not a great option, but it depends on what you have.
Yeah, so you have any long-term data on just how long that you keep the regimen to help the children get virus suppression? In how long? 1 year, 2 years, 3 years, or more? You have any data on that one?
I mean, other people have shown that you can, with better support and regimen, you can suppress children with HIV. I mean, infants with high viral load, it's possible. But in our cohort, we don't have that data yet. Thank you.
Thank you.
Okay, thank you very much, Dr. Jintanat.